Dr. Bevan wants to ask you
Sorry. Yeah, I'm here.
Good. Wants to ask you next about your knowledge of hepatitis risks and in particular non-A, non-B hepatitis. Now, you've said in your statement that as a trainee, you knew that blood and blood products could be infective. And you've said also this in your statement, like any British doctor trained during the 1970s, I was well aware of the hepatitis B outbreak that killed patients, nurses and renal units in Scotland. What can you recall learning, whether as part of your general medical training or your junior medical work, about hepatitis and risks from blood and blood products?
Well, of course, one learned about hepatitis during courses on liver disease and in general medicine, and one met patients with chronic hepatitis, cirrhosis, and one was aware of phenomena of autoimmune hepatitis. And among this, one was also aware of serum hepatitis, which had been recognized for a very long time, exposure to blood products. Hepatitis B was obviously the most clear-cut and dramatic of those situations. And partly this was because it could be an acutely devastating disease, so that the outbreak at Glasgow, and also I know now that it was one at Guy's, was, very dramatic. A lot of very sick people. Some people died of acute hepatic necrosis. And then in addition, you had the remarkable serendipitous discovery of so-called Australia Antigen, which could actually just as well be called Hemophilia antibody, because the antigen was identified by its reaction with sera from Hemophilia patients. And therefore that one could actually screen blood for this. So by the time I took up hematology, I was aware that one of the major risks of blood-transmitted infection had been modified to the point of excluded by good serological testing of donor blood. But that obviously there were other causes of transfusion-transmitted hepatitis which were not Australia antigen positive and therefore could not be screened for. And then, as I said, it very quickly became clear to me as a registrar that patients with hemophilia were being probably given this by the product they received. So sorry, where did you?
No, that's.
I answered your.
You have, just dealing with. You referred to the outbreak in Scotland with the devastating consequences it had. Had you been aware in the 70s of the outbreak at Guy's Hospital? I know we've supplied you with an article that refers to it, but was that something you can recall being aware about at the time?
I think I was. The one at Glasgow was very prominent, and for the most superficial of reasons, which is that a serving doctor was one of the first of many to write a novel about it called The Houseman's Tale, which was published while I was a house officer in Darlington, which was an extremely, how can I put, almost crazy in terms of the workload. And so I was desperate for some kind of relaxation. So because there was this book called The Houseman's Tale, I read it. I think it's actually quite a scurrilous view of the Glasgow outbreak, because it invoked sexual transmission as the main, which is almost certainly not true. So, but nonetheless, that's the way in which things achieve prominence in your mind. So I then took care to actually familiarize myself with the true nature of the Glasgow outbreak. But the Guy's outbreak I probably did know about, but it was like in second place, although it was a much bigger outbreak, in fact.
And do you recall reading about or learning about, at the time, the outbreak at Bournemouth that was reported by Dr. Krask in 1975 in The Lancet?
No, I wasn't aware of that one.
Now, you said in your statement that you knew before 1979 that most severe haemophiliacs were being infected with serum hepatitis. And do I correctly understand your statement as reflecting your understanding that by this time serum hepatitis was essentially the same as non-A, non-B hepatitis because testing for hepatitis B was now available?
Yes, and hepatitis A had its own clear-cut clinical features. So I don't think I can say with any confidence which year the designation non-A, non-B very first appeared or became common currency, but I guess it was the late 1970s.
So there came a point in your practice and in the dealings and interactions you had with others where the term serum hepatitis effectively became replaced by non-A, non-B hepatitis?
Yes.
And you've said also in your statement that up until 1979, this infection was presented to trainees by their mentors as inevitable and harmless. Can you elaborate upon that?
Well, once again, I think I've unaccountably generalized that statement. It was mentioned to me by my mentor as generally harmless and inevitable. The inevitable bit was probably correct in terms of commercial blood product exposure or even any pooled donor product exposure on a regular basis. But classically, it happened during the very first few exposures of a child, for example, or a young person to any kind of commercial concentrate. And that was the way I think it was explained to them, that this is inevitable. It's just a disturbance in liver transaminases, so-called transaminitis. There's no jaundice, so it can't be. Completely unacceptable. What's the right word? Assumptions. As it turned out, and probably even in principle, to assume that something is harmless.
And you've said in your statement that you've got a recollection in 1979 of attending a UK HCDO meeting and hearing a talk from Dr. Krask, which effectively led to your understanding that non-A, non-B hepatitis was something to be taken seriously.
Absolutely right. I'll have to apologise again for memory, which, as we saw in the case of cryphosipidate, is not a quantitative thing. It's a kind of images stand out, and Dr. Krask was quite a recognisable speaker of the podium. He had a huge shock of white hair, and it was, you knew when you were being talked to by Dr. Krask, and so I just remember that and thinking, yes, well, this authority is taking it seriously, and we all should.
And just so that we can give a probable date to that, I'm just going to put up on screen the minutes of the November 79 UK HCDO meeting, showing that it's HCDO 5015_068. And we can see from the top of the page, minutes of the 10th meeting of UK Haemophilia Centre Directors held in Oxford, 20th and 21st of November 1979. And then we can see amongst the list of attendees as being present both days, yours is the, I think, fourth name down, yeah. Dr. Bevan, St George's Hospital. And I think this is right, Dr. Bevan, you were effectively attending in Professor Flute's stead, and you'd done so also the previous year in 1978.
Yes, I think this was a mixture between his encouragement of my attending of events such as the Hemostasis Club and actual deputation in that he couldn't go himself. So he wanted the centre always represented there. So I was the point person to do that. Yeah.
And if we go on, please, Shomik, to page 18. No, sorry, if we go back It's page 18 if you look at the pagination at the top. So go back perhaps 3 pages, Seamus, my apologies. That's it. It doesn't necessarily give the flavour of everything that was being said by Dr. Krask, but we can see here that on day 1 of the 2-day meeting, there was a report by Dr. Krask of the Hepatitis Working Party, and we can see that there's a discussion halfway down that long paragraph saying it was important for the incidence of chronic hepatitis in haemophilic patients to be assessed. Much discussion regarding the incidence of chronic hepatitis in haemophilic patients, the possible value of liver biopsies, and then there's a discussion of liver biopsies and a discussion of the possibilities of obtaining samples post-mortem, discussion of attack rates. Dr. Krask commented, this is towards the bottom of the page, Dr. Bevan, that most patients thought to have developed chronic liver disease had not previously had an overt attack of hepatitis. There were various possible causes of hepatitis. If we go over the page, one should keep an open mind about it. 2 types of non-A, non-B hepatitis, and then a discussion about forms for reporting cases of chronic hepatitis. So is it fair to say this is probably the occasion that you have a memory of?
Yes. Yes, it is. I'm assuming.
So is this a fair way of putting it, that from at least late 1979 onwards, you as a relatively junior doctor still at that stage understood that non-A, non-B hepatitis could be serious, or put another way, it wasn't something that was inconsequential or benign and harmless?
It certainly wasn't inconsequential. I mean, one of the difficulties was the distinction that was being made at that time between what was called chronic active and chronic persistent hepatitis. So chronic hepatitis could be of the type which was at that time classified as chronic persistent, which was thought to be not progressive towards cirrhosis, whereas chronic active was regarded as potentially progressive towards cirrhosis. And so for a time, that belief that non-A, non-B hepatitis had a harmless element, or in some cases it was harmless, was based on the fact that the finding on liver biopsy was of the chronic persistent type of hepatitis. So there was still some, there wasn't the absolutely clear-cut role of the hepatitis C virus, which of course it eventually became, where we understand that there is no innocent type of chronic hepatitis associated with it.
We can take the document down, Seamus.
Yeah.
Can you recall whether post you're hearing that talk from Dr. Krask in November 1979, can you recall whether you had any further discussions with Professor Flute about how non-A, non-B hepatitis should be regarded?
I do not recall any such discussions. I kind of understood that when he was being deputized that he would go through the minutes, and he would have been aware of that. And then, of course, there was Eric Preston's paper on biopsy, which was very close to that.
Yeah, and that was, in fact, the next matter I was going to ask you about. I'm not going to turn to it unless you want to look at it in detail, Dr. Bevan. We've looked at it on a number of occasions in the inquiry. It's 1978, Professor Preston's publication, liver biopsy results, including findings of chronic active hepatitis. Did you read that at the time, as far as you can recall?
I wish I could claim that I read it in detail at the time. I think the implications of it were clear from its publication, not least because, of course, at UKCO meetings, a fair amount of stuff takes place on the podium, but other stuff takes place in conversation with peers. So some of the younger, some people of my similar age and stage as I was, like there were members of the Sheffield team, Macris, for example, who were involved, and it was clear from conversations that this was a highly significant finding. I mean, there was no way. I mean, Professor Flute was of the generation of haemophilia doctors where I think wild horses would not have driven him to do a liver biopsy on a patient, because he was part of the group that felt it was completely impermissible. But I think that was a prominent finding and that was well appreciated at the time, and I think by me as well.
Do you recall whether you saw the December 1975 World in Action documentary, which talked about hepatitis risks and blood donation practices in the States?
I don't think I saw that documentary.
Do you consider that, as a matter of principle, patients should have been told about the risks of non-A, non-B hepatitis and that they could potentially have serious consequences, at least from 1979 onwards?
I think that's unarguable. I don't think anybody would claim that they should not know that, since we knew it by then.
But I think from your earlier answers that, again, please correct me if I'm wrong, you don't know whether Professor Flute's advice to patients changed at all about non-A, non-B hepatitis.
I'm afraid I have no knowledge of that. I would hope it did, but I can't say yes or no.
What was your practice from the point in time at which you became the responsible consultant for the haemophilia patients at St George's, so summer of 1985, in the sort of years that followed in the second half of the 1980s, prior to the availability of the hepatitis C test? What was your practice in terms of the information you'd provide to patients about non-A, non-B hepatitis?
As far as I can recall, and I would certainly hope, my practice was to inform them of the risk of non-A, non-B hepatitis and what was known about it at the time. Yes.
And
I think in this, I was informed also by as I tried to say, the HIV or the AIDS epidemic changed everything. And one of the things that changed was I became used to working with a counsellor, and she was, if you like, she became interested as well in Hep C. So from then on, my practice moved towards complete disclosure of risks, I think, at the outset. We still regarded consent to treatment with concentrate as categorical. That is, not to be renewed on every exposure necessarily. But I did put people in the picture.
Moving to the question of AIDS, again, you've said in your statement that you recall reading, and I think you've put it as late 1982, an MMWR report of AIDS in haemophiliacs in the United States. Is that right?
Yes, I think I do. I mean, the MMR obviously is
MMWR.
MMWR is not something that British haematologists would normally consult, but the fact is it was published as a supplement, a kind of digest of MMWR findings were published in the Journal of the American Medical Association, as far as I remember. And this was a journal I did read. It was one on my kind of chronic reading list. So I'd read that, and I was aware of it, and I was alarmed by it, as you would expect.
And you put it this way in your statement, having read that you knew that people with haemophilia were at risk of blood-borne infection because of their exposure to pooled plasma from mini donors. So the association, as I understand it, between blood product usage and AIDS seemed quite likely to me.
Yes, at that time, I think I remember describing it as, the person with haemophilia exposed to multi-donor blood products being like the canary in the coal mine for any blood-borne infection, and this would be not just information that led to me regarding them as risk, but also, quite good information suggesting that you were looking at a blood-borne virus or a blood-borne infectious agent, I should say.
Now, we know, and you will have seen this in some of the materials supplied to you for the purposes of your evidence, Dr. Bevan, that there were also in December 1982 reports of AIDS or AIDS-type symptoms in patients who had been transfused with platelets. There's the San Francisco baby case. Yes. Do you recall becoming aware of that as well?
Yes, I think those early publications on AIDS in the New England Journal and others were top line reading, I think, for all of us.
I'll come on to such discussions as you had with Professor Flute on the issue, but before we do that, can you recall what, if any, discussions were had around this time, late 82, first few months of 83, with others, other doctors in the hospitals in which you worked, for example, the Royal Marsden?
No, by then, so where are we talking about now? 1982-3. I think my relationship with the Royal Marsden had essentially ended. I had no more attachments there. I think, and the Royal Marsden is a rather enclosed cancer world, and I'm not sure. So no, I don't recall having any discussions with them at that time, even on the issue of Kaposi sarcoma. I don't recall discussing them.
Can you recall, for the first half of 1983, where were you in the rotation that you were undertaking, the senior registrar rotation? Were you at St James's Hospital, or were you predominantly in St George's at that time?
I think I was at St James's. I was attached to St James's Hospital, but unfortunately my precise CV seems to have got lost in my loss of electronic documents post-retirement. So I can't say for sure, but I think it was St James's. So because I think that would fit with my recollection that the first few months of my consultant appointment were at St James's, that I kind of continued that relationship.
Can you recall when you became aware for the first time of the first haemophiliac patient in the UK thought to have AIDS, the Cardiff AIDS patient?
I can't remember that with any certainty. You're undoubtedly going to ask me about the conversation that at a teaching session we had with Professor Flute. I've got a feeling that we hadn't had a British case then, and that was part of his response.
Oh, can you
I can't remember for sure.
Can you describe for us that conversation that you recall you and I think Dr. Richard Lee, another trainee at the time, having with Professor Flute?
Well, I can recall that we were assembled at the St George's base, and we were in fact sitting in the hemostasis laboratory. And because Richard was there as well, he was a colleague of mine, Dr. Richard Lee, similarly a lecturer, and we were both preparing for the MRCPEF, and I think we probably attended a teaching session on hemostasis in the laboratory, and therefore we had a moment where Professor Flute took us through what we'd learned, and as part of that discussion, I can't remember. I think it was we more or less raised it jointly with him. Had he read this? Did he not think that this was a transfusion transmitted condition for which all our haemophiliacs would be at risk of, particularly those who were receiving American concentrate? And I just remember his response. I can actually, as I said, in the narrative way, remember these things. I remember sitting in front. It was a sunny day, and he was sitting by the window, and he was, in his usual way, kind of gruffly, jovially, said that he didn't regard this as in any way a proven infection. At that time, he was an editor for the BJ, British Journal of Haematology, and he said he'd seen recent submissions of papers showing similar disorders among T-cell subsets in a bone marrow disorder known as myelodysplasia, which has nothing to do with haemophilia, and who are not treated with similar blood products, but do get a lot of red cell transfusions, sometimes platelet transfusions. And he said that as far as he was concerned, the findings in the American group were just typical of people who had received any kind of transfusion therapy on a regular basis. That it was, if you like, an immune system adjustment to being exposed to other people's blood and their HLA antigens and other foreign antigens in that material. So he went into some detail, and then as a second part of the explanation, he explained that in no way would he take any action in terms of changing infusion practice in haemophilia unless there was official firm guidance from the UK HCDO so to do. And at that, as was a bit typical of Colonel Flute, the discussion was over.
In terms of that second reason, and the way you've put it in your statement, is this: he explained that it was essential in times of uncertainty, particularly for smaller centres, to stick closely to the current guidance from UK HCDO, which at that time was not to discontinue US concentrate or revert to cryoprecipitate, and he gave additional weight to UK HCDO being supported by the Haemophilia Society in this opinion. As far as you can recall, was your understanding that that was a view personal to him, or did you understand it to be, in fact, the position of UK HCDO that smaller centres should fall in line with UK HCDO's recommendations?
Definitely. I mean, I don't know whether there were any real dissenting voices, either UK HCDO. There may have been warning voices, but I don't think actually anybody dissented from the general view. I mean, of course, this was informed by the structure of medical negligence thinking at the time, which was based on the Bolam test. So by and large, I don't have to tell you about the Bolam test, but if you were following the advice of an authoritative group of clinicians in exactly the same field, if you were following their advice to the letter, essentially it was very difficult to convict anyone of negligence. Whereas if you had gone away from their advice, you would have become vulnerable to claims of negligence. So if anything bad happened as a result of switching people off their concentrate, then you would be in open view, sort of thing. So I can understand why he was emphasizing that we didn't have the power as a small centre to go off on our own track.
In relation to the first of his reasons, and acknowledging that you and Dr. Lee were the junior trainees at this point, and that Professor Flute was, as you described, the colonel in the Territorial Army, did you and Dr. Lee express a different view that you can recall? Were you impressed by his reasoning?
I don't think we chose to quarrel with him. Unfortunately, I cannot claim that we quarrelled with this. You would have to ask Richard whether he felt we were sufficiently, or we just dropped it at that point. I would draw a distinction here, of course, that this Dr. Lee is not the same as Dr. Christine Lee,
No.
who was also actually a trainee in the department under the part-time women's scheme. But
Yes.
This was Richard Lee.
Yes, and we have a statement from Dr. Richard Lee, I think, in any event. Given that, to your mind at least, in early 1983, there was a likely association between the use of blood products and the development of AIDS or AIDS symptoms in haemophiliacs, would you agree, as a matter of principle, that patients should have been told of that possible or likely risk at the time?
Well, I think they should have done, but obviously if I was coming from the same position as Professor Flute, I would have thought that it was necessary to have a further degree of proof before you confronted the patients with it. Yeah, that's mine.
And do you know what, if any, information or advice was given to patients as a matter of fact? It may seem from Professor Flute's words to you and Dr. Lee that he may not have given patients warnings, but do you have any knowledge yourself of that?
I really have to say I don't recall any evidence that he raised this question with his patients, and that would be slightly reinforced by my own conversations with them when I actually did, when I shared the news of their seropositivity with them.
And is this correct that as far as you know, there was no change of treatment policy at St George's in response to the risk of AIDS until the switch to heat-treated products in early 85?
As far as I know, that's the case.
There were various communications from UKHCDO to centre directors in 1983, as well as the annual meeting. There were some letters marched in June of 1983. I'm not going to take time going over them with you because, as I think from your earlier evidence, you were predominantly at St James's at this time. But was that material that you routinely saw? Did Professor Flute share with you and Dr. Lee and other trainees information received from UKHCDO?
I cannot recall having that information shared. Of course, I followed the evolution of the subject through the medical literature, but from UKHCDO, I cannot recall explicitly being shown their conclusions.
Okay. Now, we'll pick matters up there now in 1985 and the move to heat-treated product. Shamit, could we have CBLA 302049, please? So we can see this is a letter from Professor Flute, February 1985, to Dr. Snape at BPL, and he is asking for a supply of heat-treated factor VIII concentrates for patients named in an attached list. Two categories of patients. First category, those who had not received treatment in the past year, and few may do so in the year to come. And then category 2, patients who'd all received treatment during 1984. And then it says this, the HTLV3 antibody status is under active investigation. Is this right, that you understand that reference to the active investigation to be to the fact that samples had been sent to Dr. Tedder for testing by this time?
Yes.
Do you know whether prior to this letter in February 1985, there had been a switch to commercial heat-treated concentrates at all? Or were patients still being treated with unheated concentrate in early 85?
Oh, this is obviously quite a crucial thing, which unfortunately I cannot recall. I did visit St George's once or twice after hearing of the IBI to see if I knew any places where the records of treatment documentation were kept, because it was all noted down in kind of Dickensian lodgers, exactly what. So, and I was not able to access patient histories, which would have letters and other clues in them about exactly what was being used during that time. My feeling is that during 1985, certainly by July 1985, I would hope that none of the factor we were giving was non-heat treated. But I cannot be certain of that. There may have been some residual non-heat treated material that was used at some time during 1985. So I apologize for not remembering that.
Your recollection in your statement from your approach from the middle of 1985 when you took over onwards was that for the most part over the years that followed you were using BPL-8Y and BPL-9A. And you've said...
Well, 9A is easy to say because I think we've always, as you can see from past returns, the Christmas disease patients nearly all got a BPL product of one form or another. Or before that, the Bidwell product, and we never had to go to commercial 9. when it comes to factor 8, I, I cannot avoid a suspicion that there were some unheat treated batches used up until the middle of 1985, but quite honestly, whether through wishful thinking or not, I do not think we gave, from my attendance, any non-heat-treated product
And
from July 85 onward.
And you've said in your statement you don't have a memory of using commercial concentrates from when you took over in mid-1985 onwards, but it could have happened due to shortages of heat-treated
Well, we definitely
BPL
used
products.
commercial concentrate, but my feeling was it was heat-treated.
We can take the document down, Seamus. Now, if we come to the question of the testing and informing patients of their test results, your understanding is that Professor Flute had sent samples in the early part of 1985 to Dr. Tedder at the Middlesex Hospital. And is this right? That was not on stored samples because St George's didn't maintain a bank of stored samples. Is that right?
I cannot say for certain that none of them were stored samples, but I know that we had no bank of stored samples. So I guess it was when I said he would have started sending them to Richard Tedder's lab when he wrote that letter to Dr. Snape in December 1984, and that process of sending samples to the Middlesex may well have occupied several months of 1985 before all the samples he could get were there. And I believe that the agreement by Professor Tedder to test samples for British Hemophiliacs put a considerable load, so he wasn't able to test them all at once. So there was a kind of queue and a backlog, which was eventually resolved. And as far as I remember, again, one's memory is slightly suspect on this, I received all the results simultaneously very soon after starting as director, which was, to say it was a wake-up call was too trivial.
But before we come to that, do you know whether the patients whose samples were sent off to Dr. Tedder were informed that they were being tested for HTLV3?
Unfortunately, I can certainly say that I have no idea. I do not know whether they were informed of the purpose of those samples. I think knowing the patients and Professor Flute, I think it's likely that most of them were. But on the other hand, I had certain evidence from when I eventually came to tell parents of children that may not have been the case with children. So I cannot say either one way or the other whether they were informed or not informed.
Now, as you've referred to, the task of telling patients the results of the HTLV3 testing fell to you in the summer of 1985 when you took over from Professor Flute. And I think your recollection in your statement was that the test results arrived shortly after you took over. That's
my memory of it.
Do you know whether the likely infection of some of his patients with HIV was a factor in Professor Flute's departure?
No, I can't say. I can't say.
Now, you didn't have access to records for the purpose of making your statement, but your recollection as set out in your statement was that there were between 15 and 18 patients who were infected with HIV, one patient with moderate haemophilia A, one patient with haemophilia B, and the remainder patients with severe haemophilia A, of whom 3 to 4 were children.
That is the limit of my memory. That may not have been precisely right, but I think that's as I remember it.
Could you explain to us how you went about the process of informing patients of their positive results?
Well, as I said, because of my training at the Royal Marsden, which had a very formalised view of how to give patients bad news of all types, and in terms of cancer hospital, sometimes the worst conceivable news. I used the processes that I had learned there, which are the principles, were that the patient was informed by the consultant in charge of their case. The patient was informed in confidence, but obviously they could bring a close family member or other supporter with them. That if there were other people present, this was cleared with the patient beforehand, and their potential role was also introduced. That basically you told the truth. You didn't hedge it. You didn't euphemize it. You told them the truth, and you then began after a period to talk about, in cancer terms, of course, the possibility of treatment, what was going to happen, and the percentages. And unfortunately, obviously, with the HIV situation, one could not say there was any treatment apart from we would treat any infections that arose as a result. So I think I obeyed those principles. I think I did it confidentially, usually in clinic rooms. Well, later, when we were given by the health authority funding for a counsellor, who, to my terrible shame, I still can't remember the name, but she was a very good supporter in further information and in transmitting things like safe sex recommendations to our patients and so forth. So sometimes from a later point, she was present. Obviously, I wasn't able to tell everybody instantaneously, but that's as I recall it. I think I told them the truth. But of course, there was a great deal of uncertainty then at that time. It wasn't like giving a diagnosis of cancer where you knew the epidemiology and the outcome chances.
In terms of your general approach, I'm just going to read, if I may, Dr. Bevan, the way you've put it in your statement, so that those who are listening who may not have read your statement can understand. You said that in your statement, the Royal Marsden Hospital ethos is to be utterly honest with patients with bad news, including the worst news. Only complete honesty can be the basis for valid patient consent to treatment, including palliative treatment. In addition to imbuing trainees with this principle, the Royal Marsden Hospital also gave us invaluable training in giving bad news. Part of that training was that bad news had to be given verbally, in person, in confidence, by the responsible consultant. That, as far as you can recall, was your approach to informing patients.
I hope and think that I did that.
Can you recall what, if any, arrangements were made for the testing of partners?
I think this was introduced subsequently, and we did offer to test partners in principle, and indeed I think most partners got tested. I mean, not all people with haemophilia have partners, but I think we did do that testing. We certainly offered it.
And can you recall whether any partners tested positive for HTLV3?
I think one partner tested positive, and I think there were other factors which might have led to that, which I'm not sure. Both had other practices which might have involved transmission. No, mostly we found where people did have firm partners, the partner was usually negative, and so through later months and years, we pursued a sperm washing so that they could try for children. So, and I think at least one couple did have children subsequently, safely, after interventions like that.
And what was your approach to telling the parents of children and children themselves in relation to the 3 or 4 children who'd been infected?
I mean, obviously, I won't have to say that this was the most difficult situation or the most painful situation. I think I'm pretty sure I pursued the same thing in terms of telling the parent. Um, Family structure in haemophilia is often a single mother. Tragically at that time, not so often now, but in those days, often the fathers somehow used to disappear from the scene, and the mother was left as sole carer for the child. And so nearly all, I seem to remember that those discussions, thankfully I didn't have a huge number of affected children, but those conversations were held almost entirely with the mothers. So I think I was honest with the mother. Then whether one informed the child depended on the age of the child. And I think here one would generally follow the kind of Gillick competent, Fraser competent model after the mother had the chance to think about it. Because obviously I'd be guided very much by the mother in what I told the child, and we tell them together. And I think I can remember one child that we spoke to together in that way. And then as in later years, obviously, as the children grew up, they came into the knowledge one way or the other.
What was your practice, the centre's practice, in relation to GPs being given this information?
I think that the approach I took was to get the guidance from the patient on this. Did they want their GP to know? I certainly applied no blanket provision that I would I would, on principle, let all the GPs know. I would discuss that with the patients first. The same thing, even more so, went to non-medical things like schools. That was, again, a difficult. I'm not sure anyone ever solved that issue. Protecting a child from victimization at school. And I think sometimes people tried with the best intentions and it didn't work. They weren't saved from victimization at school. Later, when we had the counsellor, we used to plan the possibility of a school visit where the school nurse and head teacher team would be cautiously informed. As far as I know, none of my patients were overtly victimized at school, but I can't say for sure. It was a very, very difficult situation to control.
Just ask you more generally about the decision-making structures that were in existence to look at risks of transfusion-transmitted infections in the late 70s and first half of the 80s. You've described in your statement the only St George's body that you were aware of was the Blood Transfusion Committee, but you've said that as far as you were understood it, they were preoccupied with ensuring the prompt and plentiful supply of blood for surgery, and safety was seen as secondary to the maintenance of supply. Is that correct?
That's the way I see it. I mean, it may be a caricature of the way the blood transfusion, but I think it's fair to say that the blood transfusion system, the supply was like 9/10 of the law. The one fear they had was running out of blood for transfusion. So as you'll see from future action, they were, for a while, very unwilling to, or very, very conflicted about introducing, for example, Hep CV testing, hepatitis C antibody testing on donor blood, because they thought it might actually dissuade donors and cut the donor number below a critical point. And this has always been a huge issue for them. So that blood transfusion system was obsessed with the availability of blood, the non-wastage of blood. So I can remember the director of the NBTS, when he appeared to talk to clinicians under his jurisdiction, the talk would always be about, you're wasting blood, you're ordering too much blood, we'll run out. They were obsessed with it, quite frankly, and one can understand why. Since the blood transfusions service was started, running out of blood has been the dominant. So yes, the Blood Transfusion Committee was committed to supply of blood, and they may have discussed safety, but I was never an active participant because it was a blood bank thing. Dr. John Parker Williams usually covered that committee, so I can't say, but I don't think, either from the minutes or anything else, that H of A and non-A, non-B was ever discussed at the Blood Transfusion Committee.
And in terms of the Southwest Thames region, more generally, you've said in your statement you think it probable that there were meetings held within the region by the Blood Transfusion Service or at Tooting to consider transfusion safety, but it wasn't something you or your colleagues were party to or provided with information from?
To the extent of my memory, no.
On a national basis, is this right, to the best of your recollection, that in terms of recommendations or guidance, it was really just UKHCDO and no other source of national recommendation or guidance to you?
I'm trying to map this against the early development of AIDS treatment units, like again at the Middlesex, whose process, whose what's the right word? Anyway, their practice began to impact to a greater and greater degree on the rest of us. So at George's, I was extraordinarily lucky to be on the site of one of the first AIDS treatment unit that was developing under Professor Griffin and Dr. Wandsborough Jones and others, whose clinical ward was adjacent to the hematology ward, and we knew them very well. So they rapidly developed counselling and began to develop their own practices, and we tended to follow them. So I think I also had internal advice from the AIDS treatment unit, its clinicians and counsellors and nurses, which helped us along.
Do you think, from your perspective as first of all senior registrar and then as the consultant who took over, that it would have been advantageous to have national advice from Chief Medical Officer or Department of Health and Social Security?
I think that would have been helpful if it had been appropriate. I mean, it might have come through UKCDO. It would likely be expressed at a fairly high level, sort of towards UKCDO. I think that the role of the Chief Medical Officer, I can't even recall who the Chief Medical Officer was, but I don't think there was an activist Chief Medical Officer in the same way as my colleague and friend Sally Davis became an activist, to appear in public, to promote certain things, to warn other things. I think they were a much more bureaucratic person in those days, much less likely to go into the public domain in a big way. So, yes, presumably it would have added impetus to the actions of UKCO if direction was coming from a higher place, but I'm not sure. I don't think it happened.
Can I ask you to move forward a few years now to the early 1990s and the arrangements for testing patients for hepatitis C? What were the arrangements that you made at St George's for the testing of your bleeding disorder patients for hepatitis C once the test became available?
As far as I recall, and this may not be 100% reliable, we were able to do such testing internally with St George's virology department. Rather than refer them outside. So that's my view. We were able to test them internally as soon as, more or less, as the test became available. So I know that Professor Savage felt that some of the commercial tests were more valid, more sensitive, more reliable than others, and so he went outside to people like Professor Tedder's laboratory. But I think we got ours internally. I don't think we had to refer them outside.
And was there, for the hepatitis C testing, a process of pre-test counselling undertaken?
Yes, I think I can firmly say that, because then we had the counsellor and we'd learnt the lessons from the HIV setting about how to do this. So again, the patients were told. I must admit that my recollections of those interviews were completely different, with many of my more experienced patients saying basically, I've got enough to worry about with HIV without dealing with this situation. Since it doesn't seem to be affecting, it goes on the back burner, sort of thing. So their approach was that yes, it was distress at this too, but also the fact that this seemed to be less of an immediate danger to them, which I think is true. So I think we told everybody correctly. I hope we did. And we should have done.
Did you, as far as you can recall, follow the same process of talking to them in person, the news being delivered by you?
Yeah, except by then I would have my counsellor alongside me. Yes, I think we'd refined it by then.
Now, again, I'm conscious you don't have access to records or data about the numbers of patients infected with hepatitis C. The estimate, I think your statement gives, was 70% of patients, at least of those seen frequently, were infected. Is that consistent with your recollection?
Of the severe haemophilia group, I think that's probably roughly right. And unfortunately, I can't claim exactitude on that.
Can you recall whether there was any particular features of the treatment of whether it was 30% or a different percentage, who were not infected that would explain why their outcome was different?
Well, some of my patients by then had actually received only heat-treated product. So this would be true of the children up to about the age of 12, maybe, that they'd only received heat-treated product. So while accepting that during the early phase of heat-treated product, some of the heat treatments were not 100% effective against HCV, they seemed to be in effect those who had only received heat-treated product were negative.
Can you recall what information you gave your patients on telling them of the hepatitis C result about the possible long-term consequences?
I told them, I'm pretty sure that I told them about the findings at Sheffield that there was a risk of chronic hepatitis. I probably wasn't informed enough in those days. I hadn't worked with hepatologists enough to understand that once there was cirrhosis, there was an inbuilt chance of hepatic cancer. To me, cirrhosis was if you like, the worst case at that time. I think I was a bit naive. The fact is also that none of my HCV seropositive patients had clinical liver disease at that time. So I don't think, none of them had cirrhosis that we could diagnose with them without biopsy. I still largely did not press biopsy upon them, and I'm pretty sure my patients wouldn't have accepted it. By that time, I'd had an unacceptable experience with one person that we had tried to do a liver biopsy on, and in fact, the operator had hit their spleen, which was we managed to salvage the situation, but it was very sticky for a while. So I had no great desire to do their liver function tests. Seemed okay. They might have a mild transaminitis. They had no symptoms. They had no varices. They had no clinical signs of liver disease. I referred them, or I discussed referring them to our hepatologist, gastrointestinal specialists, and they would usually agree to be referred. The specialists were a little bit, as I can say, do they have any symptoms? Do they have any signs of liver disease? If so, why am I seeing them? Sort of thing. I've got clinics full of people with established cirrhosis. But eventually they did see them, again, as I pointed out, I think we had an ultrasound doctor at that time who reckoned he could diagnose cirrhosis on ultrasound, probably an illusion. And so we put them through that, and none of them appeared to have it. So in the absence of any clinical evidence of actual liver disease, there was not much activity. And I think the majority of patients thought of it as a minor problem compared to their HTL, their HIV seropositivity, if indeed they had it.
And in terms of the monitoring of the hepatitis C positive patients for the years that followed in the 90s and the early 2000s, what were the routine arrangements for monitoring, and what was the point at which referral to a hepatologist or treatment with interferon and the other early therapies became contemplated?
Right. I think that yearly or 6 monthly, we tested the transaminases and the other liver function tests, like serum albumin, gamma GT. So some of those enzymes are very, very sensitive to hepatocellular inflammation. Others, like albumin content, would only fall during late liver disease. So you've got a bit of a spread there between tests which are either find something that doesn't have any major implication or are too late to act on. But if the liver function test became more disturbed, then I would refer them to, then they would attend the hepatologist. When it came to interferon, right, I do recall some patients of mine having treatment with human cellular interferon, like the most crude version of the drug, which comparatively had very severe side effects. And both the patients who were put on that drug couldn't tolerate it after about the second month of treatment. So one doesn't really know if they ever responded to it. That's at St. George's Hospital. So I'm still trying to think if anybody at St. George's progressed to varices or overt cirrhosis during my tenure. I just can't remember it.
Would decisions about interferon, whether...
Oh, right, sorry, I misled you there. There was one patient, a very complicated patient who died, and he was co-infected with HIV and Hep C. And at the coroner's inquest, in any case, the coroner decided to classify it as a HCV-affected occasion death. So it would be wrong to say I had no problem when I had a coroner-associated death. I think it was more complicated than that, and the coroner took family views into it. But I should not go any further in that respect. So yes, I did have one patient with a degree of cirrhosis, and I think another patient with hepatic varices. So yes, by the time I left, some of the longer-term patients had developed overt liver disease and under the care of hepatologists.
Were decisions on prescribing interferon, whether it was the early version you've described, or pegylated interferon, and ribavirin, were those your decisions, or was that something which would be dealt with by the hepatologist?
By then I'd come to the understanding that I, unlike some of my colleagues like Mark Winter, was never going to be an HIV or a hepatitis doctor, and that I used the true experts on site to manage those aspects. Of course, they'd discuss things with me if they wanted to change in treatment or there was a clotting aspect to it, but I let the experts decide.
And I think in relation to the treatment of patients with HIV, you said in your statement that there was no need for you or your colleagues at the Haemophilia Centre to become ad hoc HIV specialists because you had the on-site infectious diseases specialist unit that you referred to.
Opinion leaders and clinical scientists who were advanced in the field to help me out at St. George's. just as later I did at Guy's and St Thomas's. So,
And in the early years, the pre-treatment years for HIV, you've described the care of patients in these terms in your statement. This care became a desperate holding operation as patients progressively succumbed to the onslaught of multiple opportunistic infections. We lost 4 patients quite quickly, including one who was 13 years old. I had seen similar organisms cause disease in immunosuppressed leukemia patients, but never in concert like this, rapidly invading multiple organs despite high-dose antimicrobial therapy. The sense of helplessness in the face of a new disease that was outpacing the chasing clinicians was terrifying.
I think it was the most terrifying phase of my life, of my professional life, because of this feeling that it was running out of your control. I mean, even in leukemia and cancer situations where people have become profoundly immune suppressed, you felt a certain degree of trust in the drug regimes, whether they were antibiotic, antifungal, antiviral, that you used. And by and large, they worked to a useful degree. But in the HIV, it seemed to be running out of control. And the moment that and while you might get the frontline immune opportunistic infections under some kind of control with pentamidine inhalations, or you name it, then along would come bizarre versions of Hodgkin's disease or lymphoma in the brain or elsewhere that would eventually you would not be able to treat. Now, on retrospect, what happened was there was an early cohort of patients who succumbed to this very quickly. And then there was another cohort that seemed to have some residual resistance to this complex. And then, as I said, I had one patient who never even developed a T-cell abnormality, presumably was genetically in some way immune. But that first cohort, it contained most of the older patients. So anybody over 60 was at severe risk of relatively early succumbing. But they also had these very young patients who might have had some kind of predisposition to get severe disease. Very, 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 very alarming. I mean, to me, it brings great sympathy to the contemplating the intensive care doctors trying to deal with the first wave of COVID pneumonias, where clearly that it was something different from what they'd ever seen before. And they've learned how to manage it, and I think probably the HIV doctors did as well.
I wanted to ask you next, Dr. Bevan, about some of the reflections you've set out in your witness statement. Paragraph 50. I don't know if you have a hard copy of your statement to hand, or I can put it up on the screen.
No, I don't, unfortunately.
We'll put it up on screen then, Dr. Bevan. It's WITN 4106001, please, Shomek. And if we go to page 22, please. And if we look at the bottom paragraph of this page and the first 2 paragraphs of the next page, first of all, you say this. I'll read it aloud because it'll be easier for some of those following and watching to hear rather than read. To my current knowledge, from hearsay largely informed by subsequent written sources such as Starr's revealing book Blood, during the 1970s and early 1980s, plasma fractionation companies in the USA bid for large pools of frozen plasma assembled from up to 40,000 donors, traded on the North American plasma spot market, Toronto, Canada, by plasma brokers. The companies and brokers who participated in this market maintained a state of willful ignorance of the provenance of this plasma, which was widely known to have contained donations. We'll go to the next page, thank you. From US prison populations, so-called Skid Row blood donation facilities, buying blood for cash from street people, including substance abusers, and even donations forced from Central American villages at gunpoint by paramilitaries. They performed screening for hepatitis B on the plasma forms, but otherwise fractionated them into factor VIII concentrate. And then you say this: I therefore consider by far the dominant contribution to the scale of infection of patients with bleeding disorders in the US and UK to have been made by the commercial fractionators who made and sold infected factor VIII concentrate because they knowingly abandoned any control over the safety of their raw material. Another significant contribution to the scale of infection was made by the acts of plasma market makers and brokers involved in the sale of plasma. Now, just pausing there, and before I ask you about UK HCGO and the approach of doctors about which you may have more direct personal knowledge, do I correctly understand that what you've set out there is your view now informed by the reading of materials such as the Star Book that you've described? It's not based upon your own knowledge at the time or direct knowledge?
No, it's not. It's not based on anything I knew outside that history, as very persuasively demonstrated in the Star Book, and then obviously subsequently dealt with at some length insofar as they're in the public domain, the legal arguments of various plaintiffs, particularly in America, of American hemophilia groups against the companies involved. I must say that, so insofar as it can be backed up, the thing about paramilitaries, I think, is in Star alone. I've never seen any other reference to that. But the plasma market occupying the Canadian aspects, and the plasma brokers who traded large pools of plasma on that market, I think has all been, wherever I've seen it, it's been confirmed that it was taking place. But I have no personal knowledge at all.
We do have some material which has been offered to the inquiry which would tend to support the Central American reference which is set out here.
I mean, that's obviously absolutely horrible to contemplate.
Yes.
Now, you then continue in your statement by talking about the approach of UK HCDO and the generation of haematologists that dominated UK HCDO at the time. And I want to ask you a little more about that, because obviously that's something about which you may have a more direct knowledge and experience. I'll just, again, read out the next few paragraphs, if I may, for the benefit of those listening. The AIDS epidemic was a turning point that utterly transformed medical practice in ways analogous to the effect of a world war. The decisions and policies of the generation of haematologists that had dominated the UK HCDO and haemophilia treatment in the UK up to this point, pre-AIDS, were conditioned by the long period when haemophilia treatment was of limited availability and effectiveness. Their attitude and reactions were dominated by determination never to withhold treatment and never to run short, let alone out of treatment. This unwillingness to countenance the loss of effective treatment was shared by the Haemophilia Society. The UK HCDO also took a position in many ways typical of a British public health governance, not to risk overreaction, not to act prematurely, not to alarm the public. The evidence is not yet conclusive, we don't yet have proof. Response is still evident during the early phase of the current COVID-19 pandemic. Could we just continue down the page, Mick? You then refer in the next paragraph to factor VIII companies pulling the wool over the eyes of doctors. I'll come back to that if I may. I'll skip that for the moment. You then say this: however, taking all these things into account, the UK HCDO continued to hold the line well into 1983 that the evidence of an infectious cause of AIDS was inconclusive and that action would be premature long after that position became obviously untenable. However, by then the scale of HIV infection in people with bleeding disorders in the UK was fully established, and obviously that's a matter that the inquiry will have to determine in due course. Now, just pausing there, if I may, I'll come on to hepatitis C perhaps after the lunch break. First of all, are those observations you stand by?
I stand by those observations.
The observations you set up there remain your view.
I mean, every clinician is a creature of their generation, so I may well have attitudes that future generations will find equally not inexplicable, equally hidebound or non-responsive. So those doctors were in many ways admirable doctors, far more distinguished clinical scientists than I ever was. I would feel embarrassed confronting them with it, but the fact is, I think that they held the line to the point where it almost became like a denial problem into 1983. I think to continue to propose that there was no conclusive evidence that AIDS was caused by an infectious agent was simply, in retrospect, of course, untenable. So I still feel that way, yes.
The sense that this part of your statement gives is an observation by you that the generation of haemophilia doctors, who, as you described them, those who dominated UK CGO, was so focused on not withholding treatment and wanting to maintain treatment at all costs, that it may have been that insufficient weight was given to counterbalancing concerns about safety. Obviously, that, whether that's correct or not is a matter for the chair, but is that the sense of what you were trying to convey?
Yes, because they'd grown up during a period, I mean, they'd been trained, they'd had their early care, when the majority, in a time when, you know, the median survival of people with severe haemophilia had really stayed stuck very much in the Carol Birch area of mid-teens to early 20s, that young people with haemophilia were essentially lost the use of their joints, or many of their key joints, knee joints, ankles, elbows, by the age of 20, and there were patients confined to wheelchairs by the scale of arthropathy that had been established. Now, the introduction of cryoprecipitated in 1963 by Judith Poole changed the survivorship, but because of its complexities in giving prophylactic treatment, didn't really change the scale of joint damage. So it may have delayed it by 5 to 10 years, but the end result was still severe joint disease in haemophilia. So they saw all the downsides of not having prompt and convenient treatment. And they'd just been given, if you like, within the last 10 years, this supply of treatment of concentrate that they knew had the capacity to eradicate those problems of haemophilia. And so their attitude was conditioned by their experience of the disease. And it may still be the case that if one had withdrawn commercial factor or tried to substitute it by widespread reintroduction of cryoprecipitate, we would still now be looking at patients in wheelchairs who wouldn't have been there otherwise. So I can understand the attitude they took, but I still see it as a kind of denial of a reality.
So I have a handful more questions, but I note on this topic and then a handful of other topics to cover. But I note the time, and maybe a convenient point at which to break.
We'll take a break. We'll come back at 2:05. Same rules apply. So 2:05.
Okay. Thank you very much.